Buenos días a todos y todas. Gracias por su
Good
participación.
morning, everyone.
Estamos
Thank
esperando
you
unos segundos
for
para que
joining us.
todos
We
y
are
todas
waiting
puedan
for
entrar
a
en la
couple of
sala de
seconds
Zoom.
for
Mi nombre
the
es
rest
Rita
of
Mónica Bea, soy la
attendants.
asesora de
My
la
name
OMS en temas de
is
violencia.
Monica Bersa. My
Es un
name,
gusto poder
I
compartir
am in
este espacio con
charge
todos
of
ustedes. Es muy bueno ver algunas de las caras
everything
que
related
conozco
to
y
violence,
espero poder
and I am happy to
tener una
see
muy
some
buena conversación con
faces.
todos
I am
ustedes. Les
hoping to
invito
have
a
a good
presentarse en el chat
debate with all of you. I will invite you
para
to
poder
introduce
continuar
yourselves in the
y
chat box
comenzar
so
con
we
este
can
intercambio.
start with this
I'm going to repeat this in
webinar.
English. Good morning to all. Thank you so much for joining us. My name is Prita Monica Bear. I'm PAHO's advisor on violence. And it's a pleasure to share this space with you. And I hope that there will be a lot of participation from all of you. I encourage you to introduce yourself in the chat. This meeting has interpretation in English and Spanish. And you will be able to click on the globe at the bottom of your screen to choose your language. Este evento tiene interpretación en español y inglés. Entonces pueden hacer clic
Webinar
en su
has
globo
simultaneous
en
interpreting
la pantalla
in
y
English and
seleccionar su
Spanish. You
idioma.
may click the globe icon and select the language of your preference.
Bien. Y con eso vamos a
Very well.
comenzar.
Let's start.
Quizás ya lo saben, pero esto
Maybe
es
you know
un
this,
evento
but
sobre violencia sexual,
this
una
is
respuesta a la
an
violencia
event
sexual que la OPS está
as a
organizando
response to sexual violence
con
that
dos
PAHO is
objetivos.
actually
Primero, para lanzar
performing
una
with two
herramienta
objectives.
que ha
First,
sido una
we
prioridad de
want
la
to
OPS
launch
y
a
un
tool
trabajo
that has been a
conjunto con otros
priority to
países
PAHO.
desde hace mucho
It has been a
tiempo.
joint
Y
work with other
estoy muy
countries,
orgullosa de
and
poder
it's been
lanzarlo
a
de
long
manera
time, so I
formal
am very
y
proud to
compartirla
launch this
con todos
formally
ustedes.
and
Además,
share with all of
este
you.
evento tiene lugar
This
en el marco
event
de la comunidad de práctica. Esto es un
has
mecanismo de una comunidad de práctica
a way into
de
our community of
puntos
practice.
focales
This is
antiviolencia de los ministerios
a
sociales de
focal
América
point
Latina
against violence towards
para
Latin
poder mejorar el
America
intercambio
in order to
regional sobre este
improve
tema.
regional
Esto es
exchange
un
on
desafío
this regard.
que
This
muchos
is a
países y
challenge
todos
that
nosotros tenemos en
many
común
countries have in
y
common.
creo que hay mucho valor
And
en
I
poder
believe that
intercambiar
there's
y
lots of
aprender de las
value
experiencias
in
entre
the
países y
information
el objetivo de esta
exchange
comunidad de práctica
between
es poder
countries. The
tener un
community of
espacio
practice
un
would
poco
like to
más
have
menos formal
a
para
less
intercambiar
formal space in
experiencias,
order to exchange
compartir sugerencias y pensar
experiences,
juntos y juntas en cómo podemos abordar
share
este tema. Por
suggestions,
eso, el
and
tono
be
de este
able to
evento
tackle
o el
this
formato
topic.
de este evento es un poco diferente. Es un webinario, entonces esa vez este evento está abierto a un público un poco más
So
amplio.
this is open
Pero
towards
para mí es
a
muy importante
open
poder continuar con
audience
este
today, but
intercambio
it's important to
informal
continue with the
de lecciones
informal
aprendidas, de buenas
exchange
prácticas,
of
sugerencias,
lessons
porque
learned,
reconozco
good
que todos
practices and
ustedes están
suggestions,
trabajando
because I
en este tema
acknowledge
cada
that
día y
all of
tienen mucha
you are
experiencia en
working
cómo abordar la
in
violencia
this topic
sexual.
every day. You
Les
have lots of
invito a
experience on how to
presentarse en el
tackle
chat,
sexual
a
violence.
compartir sus comentarios,
And I would like you
levantar
to
la
introduce
mano
yourself in the
y
chat
poder
box, share your comments,
continuar
work hand by
con
hand,
esta
and
conversación cada
continue
día.
with our cooperation,
Entonces,
which
con
is quite
eso,
rich.
para darles una idea,
Without
tengo una
further
pequeña
ado,
presentación sobre la
and just to
herramienta
give you
que
an
vamos a
idea, I have a
compartir,
small presentation on the tool that I'm
que
going
muchos de
to share
ustedes
with you
ya
today.
conocen.
Many
Y
of you
dado
know
que
it,
es un trabajo en
but
común con
since
muchos
this is a common
países,
work with many
tenemos
countries,
presentaciones
we have
de países y oficinas del país que han
presentations
trabajado en este
from
tema desde hace mucho
countries
tiempo.
that have been working in
Y
this
luego
subject
vamos
for
a
many
tener un
years.
espacio de preguntas y
We're going to
respuestas,
have a space for
un
Q&A.
espacio interactivo
It's going
para
to
poder
be an
escucharles y pensar juntos en cómo
interactive
podemos abordar este tema.
space in order to listen to
Y
you
con eso
and
les recuerdo
think
de nuevo
together
usar el
how we
chat,
can solve this problem. I
intercambiar
would like to
todos
invite you to use
nosotros,
the chat box,
presentarse en el chat
introduce yourself
y poder continuar con la conversación.
in order to continue with this
Bien, voy
conversation.
a
Thank you.
compartir mi pantalla para darles una
Now I
idea
am
de la
going to share
herramienta.
my screen so you could have more information about this tool.
Un segundo.
1 second, please.
Bien. Creo que no tengo que hablar del contexto.
Very well.
Estamos dentro
I
de los
think
16 días.
we
Es un
should
momento
not
para
talk
dar
about the
visibilidad al
context anymore.
desafío.
We are within the 16
Claro
days.
que la
It is a moment
violencia
to
contra las
increase
mujeres,
surveillance and the challenges. It is key that violence against women, sexual violence particularly, is a challenge in our region. In many contexts in our own countries, it is essential that every woman, every girl has access to services of quality, timely services that offer support with empathy without any type of judgment in order to mitigate consequences into health and well-being of women. This is not new. I have mentioned this before. Many of you have been working in this, and actually the Americas region has always had a strong leadership. In 2015, this region was the first in which all ministers of the Ministry of Health approved their own standards, and they approved an indicator on healthcare as a response to sexual violence. And in the definition of this indicator, they highlighted the commitment of all countries in the Americas to work in such topics, but they also clarified some of the topics, characteristics of a quality service to respond or as a response to sexual violence. Now, the tool that we're launching today is response to these indicators as part of our own strategy, because we have the objective of supporting in assessing the indicator and other standards, either national or international, when it comes to sexual violence. It has the objective of strengthening institutional capabilities and continue working on the holistic response from the health system. We are also able to identify gaps and strengthen our capabilities. And I would like to thank all the people that were involved in this project, because they have helped us for many years. We started reviewing literature, similar tools. We learned a lot from other tools in the market. We actually adapted this to the specific context of our region and our needs. We had lots of exchanges with focal points on the health ministries, and I am delighted because they keep supporting us. I know that many people from the ministries of health are here today, so their comments, their involvement, suggestions has always been relevant for us. We held pilot testing. We also have some presentations on the experiences of the countries. They're going to talk about those experiences. We have had held consultation with experts nationally, in a subnationally manner as well. We have had interview with the first line personnel. We have had consults with health staff, and I am happy because we have received lots of comments. And in this talk, we're going to have the final version and the implementation manual. The idea is to mention that the tool has two sessions. First of all, we have a short version, which is a starting point. It includes the minimum questions to start the assessment of a sexual violence victim. And this is something that we could do virtually. This helps us have a fast assessment. It includes a extended version as well, with a broader list of questions and indicators. It includes general topics, but particularly specific topics, for example, raw material documentation, legal and medical care. It requires interviews with the first care personnel and the chiefs of departments as well. And for example, we know about the situation in Chile in this particular context, and it's important to be able to extend against violence.
Where a key aspect is related to the technical work in preparing the tool, but also in implementing it and using it. That's why we are having this work that is led by the Ministry of Health to obtain the technical approvals, the official approvals by the ministries to get and adapt the tool according to the national or local context, including the need of adapting it to the national protocol. This aim at help for facilitating the work of the Ministry of Health with the PAHO support. And the most important is that the tool will be able to respond to the needs of the country. This is a work that is very aligned with local stakeholders, health staff, health agents to be able to work in the pilot areas or the areas where the tool is being implemented to make decisions on the methods that make sense in this context. And this is a work to be completed to have a follow-up of the report or data that should include not only a work to analyze the data, but also a communication with the civil society, the different sectors, the different health programs, the decision makers in the health system, to be able to use the data to implement the lessons learned with the tool, to have a continuity in the work in the health sector, to face sexual violence, and also to strengthen the quality in a continuous manner. This is the main tool that should be useful for ministries of health who will continue working on this topic that is both a challenge and a priority for all of us. Why is this a continuous work? According to the tool that is part of the agenda, it emphasizes the need of working, for instance, with civil society organizations to highlight the voices of survivors and users of health services, for instance, through a dialogue with the community or with a group of women to incorporate their expectations. We need to have a coordination of this information with other mechanisms in the health system through the implementation of the protocol or analysis of administrative data to continue working on this topic and take advantage of all the data available to improve the response. And this is a collaborative work. That's why I invite you to review the tool, to think of how to adapt to your context, to help us to disseminate this tool, to use it to inform the technical work. We are working with some of the countries and implementing some articles on the pilot experiences, as I mentioned. For me, the work with the countries, especially with the 6 pilot countries, was the most important part in developing this tool. I think especially the collaboration of Argentina, Bolivia, Honduras, Colombia, and Peru, and Ecuador. And we have some speakers here of these countries who are going to share their experiences. We also are interested in working with all of you to see what else we need to be able to work together in strengthening the response of the health system to sexual violence. Of course, this tool in my opinion, it's not only an achievement, this is a larger part in the agenda. We are also interested in developing other tools, and also we are interested in offering more technical support to work on this topic. This is an opportunity to promote regional collaboration and also to learn from the experiences of all the countries, all the specialists, all the representatives during the webinar today, but also in the future to continue working and changing experience. With this, I would like to let you know that the tool is available on the site. We are going to share this information on the chat. This is again an invitation for collaboration. I hope I will be able to work with many of you to continue improving the tools we already have and also to continue having lessons learned. Thank you very much. And now I'm going to close to see you all. And with this, we are going to continue with our session, and we are going to listen to the countries who were participating in this work. I would like to give the floor to Roberto Poramora. He was working on sexual rights, youth rights from the Ministry of Health and Social Protection. He's going to talk about the tool, the situation, and the work Colombia is doing to improve the response to sexual violence against women in Colombia. Roberto, can you hear us? Yes, I am here. You have the floor. Thank you. I am going to share my screen.
¿Ahí están viendo en pantalla o no? Discúlpeme.
Can you see my screen?
¿En pantalla?
Aún no.
No.
Not yet.
Ahí.
Can you see my screen now?
Perfecto.
Perfect.
Bueno, me presento, mi nombre es Roberto Puamora.
My name is Roberto
del Ministerio de Salud
Poramora.
y Protección Social.
I am from the Ministry of Health and Social Protection of the Directorate Office of Promotion and Prevention in the sexual group, sexual rights and reproductive rights, gender violence and sexual violence. Thank you for this work and other works that we've been doing in the past. Thank you for this opportunity of sharing this, because the topic of violence, as the previous speaker said, is a sensitive topic. And when I address this topic, I am not talking about data, I'm talking about people. I'm not talking about cases, I'm talking about survivors. And this is very important because the topic of violence or violences and sexual violence is a very close topic to me. In fact, I always mention this in these spaces. I am sure that we have one or more victims here. This is a very close topic. Unfortunately, in many countries in Latin America, this was normalized. We've been working on this a little bit, but I think that this tool will be very useful, especially if we can identify the levels of violence at the local level in their realities. If we can take ownership and use this tool as an assessment opportunity and an opportunity for improvement. I would like to talk about the context in the country, the behavior of violence in Colombia, especially in year 2025. We saw an increase of the cases of sexual violence, an important increase. The most affected were the group of adolescents and youth. It is very important to see how we are having a work since early childhood to eradicate this problem. And this should also be aligned with the country commitment we have signed with the ministerial conference last year. I also think it is important to show the behavior and the rates because numbers, especially when we talk about people or survivors, numbers sometimes hide things. It is essential to see how one, two, or three victims of violence in a territory can account for 10, 20, 30%, and that's a very high rate. We also need to see how the behavior of the country was on the topic of violence. In general, I try to show that when we talk about numbers, we are talking about people. And it is important to see the amount of cases of survivors, but it is also important to check the rates. You can see here how for Bogota we have a rate of 441 victims of violence or survivors per every 100,000, in Antioquia 343, in Cundinamarca 425, and in Cali 342. And here, in the departments with the highest number of cases, the territory, we see that Bogota had 34,983 victims for 2024. We also need to check the rates. You see the highest rate in the department of Amazonas, then Guaypes, Huila, Quindío department. We need to check the behavior of these violences under these two approaches. It is also important to see how the weight of violences, especially the sexual violence. We see that for year 2020, we had 103,207 cases. And we see that in terms of sexual violence, we had 24,738 cases. And we see here an increase. A very important thing to highlight here is the sustained proportion. We were not able to reduce this proportion. The proportion is maintained. In average, 27% out of all the violences, sexual violence accounts for almost the third part. Before continuing my presentation, I would like to tell you that the country has a protocol for the care of victims of sexual violence. It is summarized in these 15 steps. I am not going to read them all. I'm just going to share it here. Why am I showing you this? Because the tool has an assessment with elements that are being assessed. And this is an indirect way to assess the protocol that we are implementing in our country. And that's why I was mentioning at the beginning, this is an essential tool for the institutional self-diagnosis to identify the improvement opportunities. How was the behavior of our country when we talk about care provided to victims? We see for years 2024, the topic of sexual violence, the care provided to victims. In relation to cases that were presented, we see that healthcare accounted for almost 99%. But when we see each of the components that are proposed in this protocol, we see that at least in the area of healthcare, of mental health, we are in 87% of cases of care provision in the first 72 hours. This is around 40%. And 40% of users had a voluntary interruption of pregnancy. They were receiving the care. So we have a mechanism to assess the initial care and according to the notification, and the PAHO tool is proposing we are developing this in our country, and this is very useful to identify the behavior of the country. Likewise, we see that for 2025, we see similar behavior. The number of cases presented and the care provided account for more than 90% for physical care and the care of mental health, and it depends on the cases presented. In relation to the implementation of the tool,
¿qué nos parece importante, cierto? Que la OPS nos está haciendo un planteamiento de que esta herramienta que es de uso rápido, porque tenemos una forma de aplicarla de manera rápida.
This tool is easy to apply, and we have a way to apply this in a broader way with a tool that could be broader or extender. So this is something that helps us to complement or supplement this information, particularly the protocol that we have in our country to care for sexual violence victims. So let's talk about the methodology. This was held in two phases. The first phase was held between August 16 and 25th of 2023. Online, we applied the short version of 292 polls. And the interviews for professionals in health institutions, we only apply 15. We held this in 4 departments: La Guajira, Magdalena, Norte Santander, y Nariño. Something to mention is that the short version was 84% on women and 16% men. It is important to consider that in the short version, this ratio of men and women were distributed, and we are seeing that this prioritized the work that PAHO was doing already for its application. So this tool was applied in north of Santander, in the district of Cúcuta, in Erasmo Meos Hospital, in Ciénega, in San Cristobal Hospital, in Riohacha. This is the north side of Guajira in Colombia. This is an area that has a high ratio of indigenous communities. We applied this poll in Los Remedios hospitals, and also the district of Pasto, Santa Marta from Magdalena, and Ocaña in Santander. So it's important to mention which professionals were involved. 172 were nurses. This is equivalent to 59%. 61 professionals belong to the internal medicine, which represents 21%. 35 were auxiliary nurses, that represents 12%, and other careers, 23 people, that represents 8%. We applied 15 interviews, 11 were held with women, 4 men. When it comes to the careers or the type of professionals, we have nurses on 53%, doctors 33%, social workers in a minor percentage. In the second phase, we elaborated 175 surveys, and these were applied in several cities that were different. Like, for example, the municipality of Arauca.
En el Hospital San Vicente de Arauca se aplicaron el 56.1% de las encuestas. En el Hospital San Lorenzo de Arauquita, el 18.7%. En Santa Marta, en la clínica del Prado,
Arauca, en San Lorenzo Arauquita, 18%.
Es una clínica que atiende a población también indígena, 1%. En la clínica
In Anchihuaya, in La Guajira, 1%, Clínica Sede, 6.4%, Antioquia, which is towards the west of the country, we have Necoclis area, which is the border, and there's a migration aspect there. This was a transit zone to leave the country towards America. And this was colliding with the San Sebastián de Urabá hospital. It is important to mention that the ratio of nurses was high, it was 52.94%, other areas 19%. Talking about the survey, it was held in a face-to-face settings. We held 12 interviews. 10 were women, 2 were men. We have the careers there. We have 4 psychologists, 2 nurses, 2 doctors, 2 social workers. Talking about the results, talking about the availability of services, for us is gratifying, is something of being proud, that 96% of people manifested that they have protocols, safe spaces, and confidentiality for provide proper care for the survivors. 93% mentioned that they have personnel which is available permanently. 7% mentioned that they were not aware of this, talking about articulating in an intersectorial manner. We see that the ratio on activities was responded above 90%, and we received training on holistic care for survivors of sexual violence. 98% mentioned that they have provided psychology care and support or health care. 93% mentioned that there was the existence of an internal mechanisms of remission, which is important. 88% mentioned that there is an articulation route with other sectors, justice, protection for the survivors, and the proper spaces, and for caring for the survivors. 91% stated that their institution provides contraceptives. 95% stated that they are guaranteeing prophylactic post-exposure treatment for HIV, which is an indicator which is quite relevant. What can we mention? We have protocols for most of the institutions, and there is a provision for providing this tool. And when it comes to the second phase, we have the 3 cores. One was the evaluation of the services. The third axis was the clinical services. When it comes to these considerations, it's important to highlight that there is a concern on having these facts in the community, where 80% of the people that have responded towards this survey. And it's important that there's a concern not in 1%, only in 80%. So for the workers that are caring for the survivors, this is something relevant. They notice that this is important for their communities. Their knowledge on the victims, they are saying that 22% agree with the idea that any type of sexual violence or act of rape could be avoided according to the action of the victim. So that means that the victim would have to have a prior actions to avoid this, but it is important to mention that we need to put the burden on the aggressor. We cannot charge or put any type of responsibility on the victim. Important to mention that 26% do not agree with this, and 33% they were neutral. Talking about the health personnel roles or function, they consider that 33% need to convince women to leave their partners in case of sexual violence. 44% were not in agreement. They say that women should not be convinced to leave their partner. 22% didn't know what to say about this. And I think that this is important because proper counseling on the victims is fundamental. Yes?
Son datos excelentes.
Yes, this is excellent data, but unfortunately we only have 1 minute. Yes. And probably this is my prior to the last slide. So 90% of the people that were interviewed confirmed that there's protocols in their institution. 97% claimed that they are providing continuous care for 24 hours, which is of relevance because violence in our country is considered as an urgent matter. 91.9% highlighted that there's privacy during consultations, which is fundamental. 86.6% mentioned that they are accessing training. It is important to train the personnel. 80.2% claim that there is a reference systems. And talking about the clinical services, 88% mentioned that they are offering psychological support, and 12% are not sure if they're offering it. 70% claim that they're collaborating in elaborating safety plans. 30% mentioned that they don't even know about it. So within our protocol, this actually is not included, but what we do is we could derive this work with a shelter, for example, or with a shelter home. But it will be important to see how we can incorporate this. And 84% of the people that responded this survey mentioned that emergency contraceptives is available. This is of relevance, not only to describe this, but also provide this, because within the kit of care against sexual violence victims, it is of relevance to have this in every institutions in our country. 88% mentioned that HIV prophylaxis is available. 85% performed derivation. And the conclusions evidence progress in availability of services. We identify there's a persistence of barriers and lack of knowledge on the care that would limit the access for holistic attention, particularly talking about high vulnerability context, because we have high vulnerability because there's lots of migrants. The Colombian health system has tried to help them with temporary permits, but we are incorporating all of these subsidies as well. The second phase, it is important to consider what are the key results. We have extended the different views on healthcare system, top tier, second tier, and tertiary level, and we included the protocol on care. We identified that there was a high level of institutional commitment. More than 80% of services provide key clinical interventions. We evidenced that there was a broad coverage on personal training, almost 90% in the first phase, 86.6% in the second phase. We see that there's still gaps in applying protocol practice in some institutions, and there's intersectorial articulation and access to certain raw material is low for some of the institutions. Some recommendations will be strengthening the continuous training processes, guarantee the effective implementation and homogeneous of the national protocol in all the levels of care, go deeper on the intersectorial articulating mechanisms to make sure that there is a holistic response, reinforce the availability of raw materials because we need them, ensure coverage of services in territories with presence of migrants. Particularly, we have a lot of people that is coming to our borders. We need to promote an approach focused on the people that are surviving. Thank you, and sorry that I have gone through my time, because I believe that this is fundamental for our country, and thank you for letting me introduce this tool. Thank you.
Muchísimas gracias, Roberto. Felicidades por este trabajo. Como es súper impresionante ver los datos de Colombia. Sé que es difícil resumirlos en pocos minutos. Agradezco mucho la
Thank you,
colaboración.
Roberto. I know it's difficult to summarize all this information in just some minutes. The collaboration with the Ministry of Health and this project is very interesting to see all the different stages. This is a continuous work. This is an interesting thing that we can learn from. In Colombia, you had 2 stages of implementation, many lessons learned, and now we are going to continue. I'm going to give the floor to Ecuador. We have with us Verónica Simbanya. She is a specialist of the National Directorate Office of Human Rights, Gender and Inclusion of the Ministry of Health in Ecuador. Ecuador is another pilot country of the project. Thank you, Verónica, for your participation. You have the floor.
Verónica, ¿nos escuchas?
Verónica, can you hear us?
Sí. Verónica.
Verónica.
Si no es posible, quizás sugiero avanzar con la próxima presentación. Ahora sí. Sí.
Ya, muchas gracias.
Thank you. I was muted. Well, I would like to thank you for the invitation to our country. I would like to greet you on behalf of our authorities, especially on behalf of the Vice President of the Republic of Ecuador in charge of the Ministry of Public Health. When we talk about gender violence in Ecuador, we were having important progress in this matter.
No te escuchamos, Verónica.
We cannot hear you, Verónica. Some important elements, for instance, the interinstitutional coordination mechanisms. Can you hear me now?
Sí, funciona.
Is it working?
¿Me escuchan allí, por favor?
Can you hear me, please?
Sí, sí se escucha.
Yes, we can hear you.
Ya.
Puedes.
Continuando con la presentación, quería mencionarles que
I wanted to mention that these are the items that we are going to address: the prevalence of gender violence, the access channels and care provision that we have in the country, the comprehensive health care, and notification to the relevant authority. We have here the progress made in the country. Our country, our constitution is a guarantee of rights. It joined all the processes since 1948 with the commitment of human rights. That is also part of institutions and all the international conventions, as in Vienna, in the United Nations, in El Cairo, in different years, and in 2005 with the SDGs that were reported as country to provide information on all these processes. In 2007, we have the sexual health and reproductive health policies in Ecuador. In 2008, we have a new constitution that is a guarantor of rights, especially for gender violence. We have the Organic Law of Health. It includes the topic of gender violence, and this is very important for the actions that were taken to address the topic of health. We also have the National Development Plan since 2009 to 2030. We already started addressing the topic of gender violence in the plans, and one of the main objectives in the last National Development Plan that goes from 2025 to 2029, 2030, we already see how it addressed the National Plan on Rights and the social axis, and we also see the topic of improving social well-being, the quality of life of the population, to guarantee the full enjoyment of the health rights and the rights to education. We have a specific policy to improve the presentation of health services. And here we see that gender violence was included. We have one of the most important topics, the modification of the comprehensive organic code, the penal code in 2014, where the gender violence is typified as a problem, as a crime, to prevent the acts that are not going to be subject of impunity, and also to protect the life of people who suffer from this type of violence. Then we also have the law to prevent and eradicate violence. This is a topic that was also taking us to improve all the health issues that we are also going to mention later. And we also have the plans on prevention. This is the operational document of this law, and the Ministry of Health is working on that. And one of the most important progresses is the law of voluntary interruption of pregnancy for the cases of sexual violence. We also have policies and actions as a country, as the Ministry of Public Health. With this, we were able to identify that 65% of every 100 women suffered some type of gender violence, 56% psychological violence, 35% physical violence, 32% sexual violence. This problem is demanding in-depth measures to address this violence from the health sector. In this context, we needed to identify what to do from the health sector. We implemented many actions and developed many tools to improve all these processes. However, it is important to mention that, as in all the ministries of health, we were always addressing the gender violence. However, since 2014, we started a very important record in Ecuador to visualize even more the topic of gender violence in our country. For this, we have two access channels through the emergencies and the external consultations. Currently, we have the first aid service and also the rooms for first healthcare provision in the first aid in first care provision rooms, we have 239 rooms that are part of the emergency rooms in other health facilities where women are going to receive health care. And also we have basic and general hospitals, specialized hospitals.
¿Bajo qué proceso se realiza la atención
What are the
en estos
processes that we follow for the healthcare provision in our health facilities? We have two important things here. For the topic of sexual violence, we activate the purple code, the crisis intervention, the anamnesis, the physical examination, the psychosocial examination, the situation of users, the recording of cases, the diagnosis, the treatment, the assessment of mental health, the emergency plans to face danger and to protect the integrity of the victim, notification to the relevant authority, and the follow-up that we have in the health sector.
Que perdimos a Verónica.
I think we lost Verónica.
Verónica, ¿nos escuchas?
Verónica, can you hear us?
Parece que tiene un problema con su conexión.
I think she's having connection problems. Maybe we are going to close this presentation.
Y quizás, sí, no veo a Verónica. Qué pena.
I don't see you, Verónica. What a pity. Okay. Well, the Ecuador case was very interesting. Ecuador is one of the pilot countries that was doing a lot of work in this topic. And we will see that there are different perspectives in terms of how using this tool in the different countries. I'm now going to give the floor to my colleague from Bolivia. And maybe Veronica will be able to join us again in some minutes. Bolivia is another pilot country that we have in this project. I would like to thank my colleague from PAHO, Dr. Ojeda, who is with us to talk a little bit about what Bolivia was doing to implement and adapt the tool and the lessons learned. Hector, can you hear us? Yes, Brita, can you please tell me if you can hear me well? Yes. Okay, thank you. I would like to greet you all and thank you for the opportunity to share the experience of Bolivia. In this case, we are talking from the representation from the PAHO representation. However, this is a work that was developed by the Ministry of Health here in Bolivia, together with the Department Services, Health Services, and we were able to join all this process. We are going to briefly show you this experience in the country and how we applied the tool. First of all, I would like to tell you that the application, the implementation of the tool is within the national context. We know that Bolivia has one of the highest prevalences of partner violence in the region, around 42% in lifetime, 18% in the last 12 months. Bolivia has now a strong regulation to respond and prevent violence. We have, for instance, Law 348, the Comprehensive Care Law to guarantee a violence-free life to women. We have the law for children and adolescents. We have a model to include also the victims of sexual violence. And we have a series of technical procedures for the provision of healthcare services in the framework of the constitutional law. And we have also the clinical protocols, the use of misoprostol in gynecology, and midwifery. There is a fundamental effort to implement the tool. From the team, from the national team, the Ministry of Health, we had identified some gaps in infrastructure, in training, and also the need of consolidating an intersectoral coordination in the country to better address this situation, besides the need of standardizing the post-violence healthcare provision and guarantee a right approach. The participants of the process, as I said, the coordination was made by the Ministry of Health and Sports, in this case, under the coordination of Dr. Roxana Bigman, and two of the coordinators at the departmental level in the topic of violence in Santa Cruz and the Vaz. Here in the country, we applied both tools, the long version and the short version, in La Paz and Santa Cruz de la Sierra. In this case, we had hospitals, healthcare facilities, health offices, and primary care units. We had 15 centers, health centers for La Paz and Santa Cruz, and 67 participants for the long version and the short version. We had an online survey where we had 136 responses. As you know, the long version is an on-site version, in this case in the healthcare centers, and most of them were hospital units. This was applied in October and November in 2024. What were the main results in the implementation of the tool?
We can see that barely 50% had private spaces for care. There was a big number of trained personnel on caring against or providing care against sexual violence. We have Santa Cruz Rural or Rural Santa Cruz, where only 22% have some sort of training. There was a high availability of personnel to care for these cases. More than 84% of them had availability to tackle these topics, and 72% of these, we contacted them, and there was availability of care protocols for victims against violence. And talking about the essential services, we know that 80% has some emergencies, 79% of hospitals, and 30% of the other centers have PEP for HIV, and there's availability for treatment. And in the gaps, we notice that the care was limited, particularly on the rural areas, more than the urban areas, where there was a broader extension of 24/7 care, 24 hours a day, throughout the 7 days a week. And as mentioned, there was a lack of spaces, of confidential spaces, for more than 50% of centers for caring for this type of cases. When it comes to the psychological support through the ANIMA tool, 60% overall is implementing their strategies, but once again, on the rural areas, particularly in Santa Cruz, only 44% knew about these initiatives in order to provide care and prevention. And we identify a bigger gap when it comes to self-care plans, where only 35% were performing actions for self-care of their personnel and of the users, of course. Talking about the meds considerations, 38% considers that if women have fought back, she could have avoided this type of sexual violence. 43% believe that the personnel should convince women to leave their partners. Of course, this shows bigger numbers, 78% in rural Santa Cruz. Almost most of the percentage believe that they need to convince women of leaving their partners. Regarding implementation, we have some conclusions of interest. First, among the lessons learned, we consider that there is a useful tool to identify gaps and orient policies of health. And we know that interinstitutional involvement is key for adapting these standards, national and local standards. There is a need of continuous training with a focus on human rights, which is relevant for our personnel. And it's important to highlight the role and the relevance on the self-care plans for sustainability in their own interventions. Among the face challenges, there's critical gaps in rural areas, as you have seen. And as I am commenting this in most of the slides, all of this is oriented towards infrastructure, which is a situation that Bolivia shares with the rest of the countries in a region. And we also have some myths and some re-victimization attitudes, like, for example, this could be hindering the proper care. Of course, there needs to be a proper follow-up towards this and strengthening. And there is a lack of training when it comes to legal and medical care and managing forensic procedures when doing these interventions. Talking about the upcoming steps or the next steps for our country, this was a prior debate. We are talking about consolidating and implementing the interinstitutional acting route for caring for sexual victims, strengthening continuous training to the personnel, including ethics, gender, proper rights, warranting availability of this raw material or these tools for caring for these victims, implementing self-care mechanisms and psychological or basically psychology support to the personnel, creating monitoring systems and periodical frequent evaluation that could help us determine if these strategies are being effective or if maybe we need to modify this. With this, I would have to say that from our side, which is Bolivia, the Ministry of Health decided to undertake the challenge of implementing this tool, and we believe that we have performed the tool effectively. We have the results of implementing such tools, and we are using these results at the moment to redefine the public health policies in our country. So once again, I would like to thank everyone for inviting me, and we will be on the lookout for any question. Yes, thank you, Hector. Congratulations on your work. It's quite good to see in your presentation, for example, the tools and all of the technical work opportunities, highlighting opportunities to continue working on this topic. And this is the idea, having this priority help us identify gaps and working together in reducing these voids. And I'm going to give the go-ahead to Argentina. We have Cecilia Mazoa from PAHO in Argentina. She's going to talk a little bit about their pilot and lessons learned. Ceci, go ahead. Thank you, Brita, and thank you, everyone. Thank you, colleagues. And this moment of thinking on the implementation of certain tools and how this is actually moving forward to improving our care services when it comes to violence. It's actually something that it's exciting for me. Our work comes from working with the Ministry of Health, we were able to work with the implementation on the manual that we were able to adapt in Argentina. And we were able to incorporate a culturally adapted situation towards the needs of our country. And currently, we have a new definition on the Ministry of Health. But since this is our federal country, we are continuing working subnationally with the provinces. This is what I wanted to mention as context. Farewell. I wanted to tell you a little bit about the work background and the way that we were able to implement all of this and work different areas. And we, for example, consider the work of the city of Buenos Aires working with national hospitals throughout year 2023. And in that work context, the tool was adapted, but we also aligned this with the manual that we were working on year 2022. And we used a methodology that was mixed, where we have used complementary actions with face-to-face meetings. There was a brief online survey, and in the extended version, for example, we were able to interview 11 people, 5 with direct care, and others were involved in managing roles. We were thinking about where we needed to improve the healthcare services. And this provided a deeper analysis on how we were going to apply the tool, if the questions were suitable or not, the different barriers that we could find when working with the hospitals. Parallelly, the version included 24 answers. The response rate was minor than expected due to connectivity difficulties, workload, and of course, the reliability or the lack of trust towards virtual anonymous instruments, because some people don't know what's going to happen with the information. They don't know what's the scope. So if we don't explain this, there's lots of distrust for people, or which would be different if we visit them in a face-to-face setting, for example. Well, this took place between March and August 2023. We have worked jointly with the Ministry of Health and PAHO Argentina. And to provide more context, our country has national hospitals, province hospitals, and municipal. And just going into the results, because I know that we are quite short on time, people overall were thinking that the questions were clear, were suitable. We highlighted the need of having a unified tool to record care, talking about sexual violence and gender-related violence, because this included the data. We found that there were institutional boundaries or barriers, because there's an internal fragmentation. This is happening within the hospitals as well, because many people were not able to answer on other services. They were only able to talk about their own, because they didn't know about the processes in their own hospitals. There's people that are key, for example, for administrative data, because they don't have access to that information, or human resources, for example. And sometimes it was hard for us to reach those people to understand a little bit about the administration. of the hospital, or how were they organizing their care system to provide assistance for the people that required it. And also there was a difficulty as well to have a homogeneous look on a hospital. So every hospital was quite different. They have different complexity, different profiles, different historic moments. There was a generation of standards, of laws, and of course, clearly this included a little bit on what was clear as well. And the process enabled us to understand what were the areas of improvement. We had lots of suggestions to incorporate this. We needed to extend a little bit the options, gender identity, but we still needed to get or work with the tools that we were able to deploy. On the other hand, we needed to provide an identification on the professional roles and the profiles to adapt this towards the methodology. And there were some questions that were ambiguous and did not enable us to work with such information. Include other type of indicators of productivity. For example, it was important on the percentage of trained personnel. So for us, this was a moment of receiving more comments to understand the possibilities.
We have many important messages here. In a huge country as Argentina, a federal country with a health system that is fractioned, private, public system for the social part. We need to adapt the tool to the institutional context with a lot of innovation to think that we want to reach all the population. There were many questions about the administrative information, and that's important. We need to understand the information in the different spaces in the health sector to understand the unexpected, the expectations that are going to be solved, and also the more collaborative things at the territorial level, where we have different jurisdictions, different political views, but also different types of access to rights. And we also need to consider all these aspects when analyzing the information that is available. As opportunities, we also see an opportunity to reach a larger number of people and also to continue deepening on the analysis and also to continue with the training. It usually seems limited. We train a team and then we have to go to another team within the same institutions. There is a high turnover in the institutions and we need more flexible modalities to train the whole team timely. And I think this is also an important lesson, an important possibility to identify for working in the actions next years. We also have different provinces we want to work with in the future. We need to think of new strategies, new approaches, also understanding the whole political and regulatory context and the access to services in the different provinces in Argentina. Argentina has 24 provinces, 24 realities, and we need to face all those realities in the municipalities. It was a great experience for us with many lessons learned. Thank you very much. Thank you. Thank you, Ceci. This was an excellent presentation. As you can see, As you could see in the presentation, we have suggestions what else we need to do to improve the tool. And I would like to highlight this. Of course, PAHO is launching a PDF that will be available on our website so that it will be more accessible to all of you. However, when implementing the tool and also to consider the next steps, we need to know and we affirm that we are open to adapt the tool to the different contexts. Every context is different. Maybe we need to improve the language, maybe we need to remove questions or add questions or emphasize other topics or emphasize a specific population or group. This is the idea of the tool. This is not a final output. The launching, the publication is just a step to continue working on this topic and to adapt the tool to any context so that it will be practical and easy to work with to improve the response in your health context. That's why I thank you, Ceci, for addressing all these issues in your presentation. What other suggestions do you have to improve the tool? I am sure we have many suggestions to adapt the tool to the different contexts. And with this, now we are going to have our Q&A session. My colleague Malene is going to facilitate this session. Malene, please, I give you the floor. Thank you. Good morning, good afternoon. My name is Marlene. I am PAHO consultant, and we also have the participation of Veronica Ecuador. She joined us again. A brief question to the participating countries, the pilot countries, especially Ecuador, Colombia. And we wanted to ask you, also to answer one of the questions in the chat, what were the lessons learned for you that could strengthen the future processes of implementation of adaptation of this tool in different territories and contexts in our region, in the region of the Americas? Veronica, are you there? Could you please start? Or maybe Roberto.
¿Me escuchan ahí?
Can you hear me?
Gracias.
Thank you. Thanks for the question. I think this exercise involves to take ownership, as I said in my presentation. We think this is a useful tool for self-assessment, and we need to see how we are going to be able to make adjustment to turn it into a tool that will allow institutions to identify the gaps, the strengths, the weaknesses, and the most important, how we are going to be able to move forward to guarantee the reestablishment of rights of victims. Because here we're not only talking about procedures. This is a sensitive topic, and I think the tool is providing some elements, but you just mentioned also this, especially for our country. In Colombia, we have different regions, and maybe we will face the challenge of identifying how we are going to make some adjustments to incorporate, to implement the tool in the different territories. In the tool, we identified 4 departments. And as long as we will be able to have a self-assessment, I think we'll be also able to disseminate it more. And maybe we are going to find a way to implement the tool with its original goal, that is improving the services. Any effort that we do to guarantee that women, girls, boys who are victims of sexual violence
ser atendidas de manera humana,
first of all, be able to receive healthcare in a human manner. And I think the tool has some elements that are going to allow us to identify what are the available elements in the teams, in the institutions, what's missing. And this is one of the things that is also essential. And another thing that we need to emphasize here is not only to check what we already do have, but also to see if these elements are going to be available in a timely manner and when the victim needs it. In our country, we were able to identify it as an emergency. In the tool, we have elements that are applied to the first, second, and third level. We have many elements that are going to be useful, that are useful for us, and we need to identify more. When I was showing the data, we were reviewing the rates, the proportion that we have in the territories where we applied the tool. I was looking at other territories and I was showing that we have 1,000 per every 100,000, and that's a terrible thing. How are we going to check to identify what's going on in those territories? Where are we failing? And I think the tool is useful to identify all those opportunities. Thank you, Roberto. That's so interesting. And I would like to highlight what you just said. We need to understand the objective. The objective is to improve the healthcare services provided to the victims, the survivors of sexual violences. And with this objective, the tool is a very important resource that can be adapted and used by all the countries to achieve this objective. Hector from Bolivia, and from Argentina, our speaker from Argentina, would you like to share any lesson learned that you have experienced in your countries, in your context? Yes, I was answering the chat. In Argentina, in recent months, there was a reduction in the numbers, in the notifications. In the health system, we have a very bad registry. And recently, we saw a reduction also in the numbers of staff, and maybe that also affected the registry of cases. And we maybe need to analyze very well the data that is shown in the registry to check if it is related to a deficit in the registry or to other process that maybe somehow helped us to improve the situation of violence. The organization, the civil society are working on these numbers. The feminicides in the last semester show an increase. So we need to continue analyzing deeply, and that's the challenge. We have this challenge in the health institutions. We need to work in a comprehensive manner. We need to use all the tools that we have. They are necessary, and we need to take them to all the sectors so that they take ownership of all the things that the ministries are building, but also to identify all the other tools that we have at a regional and global level to use them. We need to include all this in the agenda. And finally, the health systems are made by everybody. We all play a role. We all have a responsibility. We need to understand the different violences as a health problem. It took us a long time to understand this. and to incorporate it in this manner in the health system. And this is the responsibility we have. Thank you, Ceci. Hector,
Claro
1
que sí, yo
minute to
creo que
share
que
one
una de
lesson.
las
Yes,
lecciones aprendidas
I think one of
es
the
justamente
lessons
la demostrada
learned
acá en el país
is
y
the
que para poder
lesson
validar este
shown
tipo
here in the
de herramientas
country.
se necesita la participación de
To
todos los involucrados,
validate this
¿no?
type
Desde el
of
principio,
tool,
el
we need the
criterio que
participation
hizo
of
fue
all those
identificar
who are
cuáles son
involved in
estos
these
responsables de
processes.
violencia en cada
And
uno
we
de los
identified
departamentos
those
y a su
responsible
vez
of
todos los
violence in the
coordinadores responsables
departments,
del
and
área de
the
violencia
coordinators
identificados
of the
dentro de los
violence
hospitales, dentro
area
de los centros de
also
salud, quiénes eran
identified in
esas
the
personas,
hospitals, in the
esos
healthcare
actores que iban a
centers,
facilitar
the
justamente la
stakeholders who
implementación de
were
la
going to
validación. Y
facilitate
ese
the
fue el
implementation
secreto
and
de
the
poder
validation of the
realizarlo
tool. And
de
was
manera
that
adecuada
was
y en un
key
tiempo
to
bastante rápido.
implement it
Entonces, en
in
definitiva,
an adequate and timely
capacidad de
manner.
poder trabajar entre todos en distintos
The
departamentos
capacity
con
to be
distintas
able to work
instituciones
together in different
definitivamente
departments
permite una
with different
adecuada y rápida
institutions
validación de
is
las herramientas.
allowing
Y
an
aprovecho para
adequate
responder rápidamente
and
una pregunta
rapid
acá, que
validation of the tools.
sin
And there is
incorporamos
a
el tema de la
question
violencia en
here,
los
if
jóvenes en las
we were
universidades. No,
incorporating
la
the topic of
herramienta no
violence
estaba,
in the
está hecha
youth in
para identificar este
universities.
tipo
This
de
tool was
violencia
not
en las universidades, más está
developed
orientada
to
justamente
identify
a
this
cómo se
type of
proporcionan los
violence
sistemas de salud
in the
desde
universities
los centros
and
dentro.
how the health
Sin embargo,
systems are
entiendo que Roberto,
responding
que hace la
to
pregunta,
these
debe tener alguna
violences
relación
from the
justamente con el área,
healthcare
con las universidades,
facilities.
y
I
los
understand
invitamos
Roberto,
justamente a
who is
contactarnos,
making this
porque tal como él
question. We
termina
invite you to contact
su
us
pregunta, dice, ¿qué más podemos
because
hacer
he's
con este trabajo?
saying,
Bueno, Roberto,
he's
si hay un
finishing his
interés, por
question. What
supuesto,
else
nuestra
can we do?
Organización Panamericana de
Roberto,
la
of
Salud acá en
course,
Bolivia,
if there is an interest
queremos
here
acompañarles
from Pajo
sin
in
plenamente los
Bolivia, we
contacta y
want to
por ahí podemos
join you.
conversar.
You can contact us and we can discuss about that. Perfect. Thank you, Hector. I would like to thank all the speakers. Brita, please, I give you the floor to continue to close the event. Thank you for your participation. I would like to thank the speakers.
Incluir a Verónica en ese intercambio de preguntas y respuestas.
Unfortunately, we were not able to include Veronica in this Q&A session. I would like to thank also the government of Colombia and Ecuador to support this process. I would like to clarify 2 or 3 things to close also this session. This tool is looking to improve the response of the health system to the sexual violence and violence against women, and also emphasizing the interviews, the work, the collaboration with the health staff at all levels. We can, of course, adapt the tool according to the objectives, and this is what the process was about. We wanted to adapt the tool to different contexts, and in theory now in Pajo we are emphasizing violence against women, sexual violence against adult women, but we are interested in working with you to look for other opportunities to adapt the tool to other groups, other opportunities that we can find in relation to this topic. I invite you to contact us, to contact the PAHO offices to find other opportunities of collaboration. I thank you. I thank the focal points of the ministries of health in the region, especially the pilot countries, for participating in this process to help us to think of solutions, the PAHO offices, the country offices. Of course, when a woman suffers sexual violence, the response of the health system is essential. The timely response, the empathic response, the quality response to mitigate the consequences of violence for women, for her health and well-being. And this tool is going to help us to do these changes, to work in a collaborative manner and also in a continuous manner to improve the response in the health systems. This will be an opportunity to continue working together. Thank you for your participation. I hope we will continue coordinating together. This will be one of many discussions on this topic, and also one of the many opportunities to share the lessons learned and continue working on the tool and other tools and experiences that we see in the region. Finally, thank you for your participation. I hope we will continue working together in the next months, years. We will continue talking on this topic. Thank you very much for your time, for your interest, and for your collaboration. We will keep in touch.